Shuman. I'm the co-chief of the Clinical Ethics Service, and it's a privilege to welcome you to Bioethics Grand Rounds. Today, we have a panel discussion dealing with a topic that has become much more germane over the last number of years regarding how we deal with patients and families when requests are made that are deemed inappropriate based upon discriminatory, biased, harassing, or other contextual components of requests. With that said, this topic is particularly sensitive. I will make the announcement early on that we will be talking about sensitive issues. We'll be using some pejorative language that's coming from patients and from others. This is all done in the spirit of trying to understand how to deal with these very difficult situations. The context behind this is that our institution has had a working group dealing with this issue for the last number of years. We have an approved policy through the Office of Clinical Affairs and Michigan Medicine to deal with this issue. And the job today is to talk about the context of how we got here, what we've discussed, what the ethical, moral, and legal implications of our work are, and what we've come up with in terms of a policy. So my job over the next 15 to 20 minutes is to contextualize and present that. And then the much more interesting and important part will be a panel discussion involving folks who are doing this work day to day. I'll briefly introduce them now. We'll go through our slides, and then we'll have our panel come join us up front. I am a head and neck surgeon and surgical oncologist and the co-chief of the Clinical Ethics Service. I'm a clinical ethicist, and that is the role that I'll be presenting today. But I'm also a doctor, Jew, and someone who deals with patients who sometimes have some not so nice things to say to us. Denise Winiarski is the Associate General Counsel for the university, who will be presenting the legal and regulatory component of what we'll be talking about today. And she was instrumental in crafting this policy and really wading through some very complex legal and regulatory waters to understand how we do this in a way that isn't only the right thing to do, but also is rock solid from a legal standpoint. Imam Kamau Ayubbi is really a wonderful, vital member of Michigan Medicine. He is an Imam who has training in visual arts and sciences. Thereafter went through the formal training to become a member of our service in pastoral care. He is a practicing Imam and a community leader who came to us via some of the Detroit hospitals and has now been with our institution for a number of years. He's also served on the ethics committees and is really a sage member of our community whose opinion is quite interesting and relevant. And Leslie Dubin is a practicing social worker who works with the Geriatric Consultation Liaison Service. Her area of expertise deals with patients with delirium and early and later onset dementia, and will be bringing the perspective from the geriatric and mental health side of how we deal with people who are not necessarily saying what they might have said 5, 10, 20 years ago. With that said, I'm going to get started. None of us have any conflicts. Some of this work has been presented elsewhere. So Michigan Medicine is actually a national leader in this area. We presented at the AAMC meeting about a year ago on this topic, and our policy has been used by many other institutions as a framework and guide. Other institutions have actually come here and sent their regulatory, legal, ethical representatives to our institution simply to learn how we did this, because creating this policy really wasn't easy. So we're going to start with 3 cases, okay? Frank comes to the ER after an assault. He has not had any head trauma. He is alert and oriented times 3. He has fractures and lacerations requiring repair, and says in no uncertain terms, "I only want real Americans taking care of me, no blacks or Jews either." Who, and now a little audience participation, who is comfortable honoring Frank's request to ensure that he has a member of the Michigan medicine community who fits what he expects to be a real American take care of him by hand? And for those listening at home, the answer is 0 people in this audience are comfortable honoring Frank's request. Next is Dennis. Dennis is a patient who served in Vietnam. He has early onset dementia. Unclear what that etiology is at this point. He also was a POW and has fairly significant PTSD. He comes and is admitted to the hospital with heart failure and says, apologetically, I just want to let you guys know that anybody who looks Vietnamese really freaks me out, and I apologize in advance, but you probably want to keep those kinds of folks away from me. Who's comfortable honoring Dennis's request? Okay, about a tenth of the audience. And finally, Miriam comes in. Miriam comes into the emergency room with abdominal pain and says, based upon my religious beliefs and cultural upbringing, I'm much more comfortable having a woman as my doctor and as my medical providers. I know you're probably going to have to do some sensitive stuff, and it would really bother me if a man was a part of that exam. So please see if you can find a woman. Who's comfortable honoring Miriam's request? 95% of the room. So the challenge is, how do you write a policy that is consistent and fair and can be applied by any member of Michigan Medicine that allows you to act differently in these three cases? And I would make an argument is that's why it took a year and a half to do this. So the problem is that people don't necessarily bring their best selves to the hospital. And quite frankly, not everybody is their best selves when they're not in the hospital. And patients and healthcare providers are challenged with being able to play nicely in the sandbox in a way that allows people to get the care that they need and to allow us to deal with ethical and moral dilemmas without necessarily sacrificing the level of care that we strive to provide. And this is hard. And anybody in healthcare knows this is hard. Whether you're in the ER at 2 in the morning and you're the only attending available and somebody doesn't like the way you look, or whether you're on the floor at noon and there's plenty of other people available, but you don't want to be excluded from providing the care that you know you can provide simply because someone is being bigoted. And the other component of this is that the only way we can do this well is if we're transparent, if we're consistent, and if we protect our own, so to speak, and look out for the members of Michigan Medicine to prevent them from feeling left out or singled out or less than qualified to do the work that we all know they're qualified to do. So our goals are to talk about the ethical and legal ramifications of what we're dealing with here, as well as to protect each other. And part of this is a matter of protection and safety. And what we're going to try to do is talk about this concept of zero tolerance. So it's very hard to have zero tolerance for biased and bigoted behavior, but allow for some clinical judgment when it comes to what we would consider a more reasonable request. So the problem is, when we make exceptions, we open up pretty large doors and loopholes, and people, very well-meaning people, can treat different people differently in different circumstances in ways that are unwitting. And the goal of a good policy is to allow some degree of clinical judgment and experience to weigh in on how we deal with situations, but also to make clear what we will and what we won't tolerate. So this involves the law, this involves regulation, this involves practice, this involves judgment, and this involves policy. And the challenge here is to get them aligned in a way that allows us to act as we want to, as leaders and best. So part of this comes down to respecting our patients versus protecting our staff. But you can flip it too, because it's just as much about protecting our patients and respecting our staff. Because it's not just about safety, it's about respect. But that respect is not unidirectional. It works both ways. And as I've talked about here, making an exception for Miriam doesn't necessarily create a situation in which we have zero tolerance for Frank. So we need to be nuanced. We also need to recognize the role of illness here. And the idea that someone with severe PTSD or someone with early dementia may be acting in a way that is really unable to be helped, but that individual is just as sick and just as vulnerable and just as deserving of care as somebody else. And our sick people who are scared, who haven't slept in 3 days, who are in pain, who are on a bunch of medications that make you loopy, are not going to act as their best selves. But part of this also requires us to recognize that the customer is not always right. That we are in a service industry and we take care of people who very reasonably might have specific demands, but that sometimes the answer is, I'm sorry, but we're not going to honor that type of a request, period. So people don't necessarily have the right to request things that we do not think are reasonable to provide. And there's a thought piece that I've written about that a number of years ago. So part of this requires a culture of respect. And that's much easier to say than to necessarily practice. So I think we all pride ourselves on being in a university that honors and respects and really elevates diversity and inclusion. Right? We hear that constantly, and it's important. There's no doubt about it. But how that actually looks when you're coming from the outside may be different than how it looks from the inside as a Michigan Medicine faculty, staff, or trainee. So what we put in a pamphlet or what we put on a billboard may not necessarily look the same when you're reading a policy or when you're actually dealing with when the rubber meets the road of how we actually interact with people. And our challenge is to try to be consistent in how we do that. So I'm going to present a bit about the law that frames this, but I have a ringer here who's going to correct all of the things that I say that are incorrect. She doesn't have a microphone yet, but she will shortly. So anybody know what this is? Denise isn't allowed to answer. So this is the signing of the Civil Rights Act in 1964, LBJ, with Martin Luther King standing over his shoulder. And the Civil Rights Act did a number of things, but Title VII of the Civil Rights Act explicitly makes clear that we cannot act in biased or discriminatory ways as employers. So that part is specific to employers. Many people would argue that the First Amendment is also of relevance here, and it is to some degree, but the part that has more teeth for an institution like ours is protection of employers, and I'll read it briefly. It shall be unlawful employment practice to classify or refer for employment on the basis of sex, religion, national origin, in those certain instances where religion, sex, or national origin is a bona fide occupational qualification reasonably necessary to the normal operation of that particular business or enterprise. So what that means is that being white is not part of the practice of medicine, and that any request for somebody who is not white to be excluded from someone's care would be a clear violation of Title VII. So that part is easy. People also reference EMTALA, E-M-T-A-L-A, so this is federal law that requires any institution to provide care to someone in an emergency, regardless of their ability to play, insurance status, citizenship, and any other number of categories. So some people might invoke, and this has happened, EMTALA to suggest that they need and request and require a provider that they deem necessary in the emergency room to take care of them. Put another way, Frank might say, I read EMTALA, you need to give me a white doctor. And the short answer is no. And there's been a number of pieces or decisions on this issue that have made fairly clear that EMTALA entitles people to care, but not to the care by someone of their choosing. So it's fairly easy to say that that argument can be dispelled. And Denise is nodding. I'm doing okay so far. And then the Affordable Care Act was passed, and in 2010, Section 1557 of the Affordable Care Act makes clear that the bias and discriminatory protections of Title VII from the Civil Rights Act also apply to anybody receiving health care under a policy that lives under HHS in the marketplace from Affordable Care Act or from any institution that takes money from HHS, which is almost everybody. So essentially, anybody who gets health care that is in any way paid for through HHS has the same level of protection. So it is essentially, it broadens the protections of Title VII to anybody getting health care under an HHS program, which is almost everybody. So it applies the workplace and employer protections to a much broader category. Am I still doing okay? Good. And then it gets more complicated because federal law, through the Supremacy Clause, will always trump state law, but state law can be more protective than federal law. So every individual state may have legislation that provides additional layers of protection that federal law doesn't. And one of the ways this plays out, which I'm not going to talk about in depth here, is with regard to issues of providers who do not want to offer a service based upon religious or moral or cultural reasons. So this is often called conscientious objection, depending upon who you read. This may be changing on a federal level within the next year or so as well, but suffice to say, you also need to know the laws of the land of the state in which you are in, not just the federal government. To my knowledge, there is no legislation in the state of Michigan that explicitly deals with the issues that we're talking about today. And I'm not going to go through this in depth other than to say that a number of people have come up with very detailed algorithms for how to deal with somebody like Frank and somebody like Miriam. And to some degree, these are confusing, and to some degree, they helped inform our policy, but we didn't use them specifically. And I'm happy to share those references in a second. One of the components of this that I respectfully disagree with is that any individual provider who is faced with a patient who says, I don't want you, has the ability to say, well, if you don't want me, I'll just go away, without it actually being escalated to their employer or their boss or someone else. I have a problem with someone being excluded and being told that because of who you are and what you look like, you have to decide whether or not you're willing to do this. I don't think that should be on that individual necessarily to decide. So what do? So we do not assign workforce to patients on the basis of any of these things. So that's clear. And a patient's preference will not be honored if it's based upon stereotyped characterizations of gender, sex, or anything else. But we do have an out. We have the Miriam out, so to speak. What we say is that we may consider a patient's request for accommodations that are related to legitimate bodily privacy concerns. So that's the out. And also go on, and again, I'm summarizing a much longer document here, to basically say that no one should ever be able to, or should be asked to tolerate a situation in which they're abused, harassed, or discriminated against by anyone. And this works both ways. So we have a separate policy to protect patients and families from bias and harassment, and another one to protect faculty, staff, and students. We also say that as a general rule, these requests will not be honored, but that in case-by-case bases, we might consider differently. So there is some wiggle room, so to speak, for clinical judgment and circumstance. So for example, gender identity based upon religious or cultural beliefs, again, the Miriam exception, and other specific cases that require individualized attention include medical or mental illness that impacts judgment or cognition. And the comments on the panel will kind of deal with some of these much more depth. And then we have a chaperone policy as well, which many of you know about, which deals with sensitive examinations. We also had to build into that gender synchrony during chaperone assignments is also important, right? So that if you're able to request a female provider for your sensitive exam, then it would stand to reason that the chaperone, in addition, would likely be assigned in a sensitive way that is understanding of your perspective. This I've copied and pasted, and I don't expect you to read it, but we have very explicit rules for how you deal with this when it happens. So when a patient is acting in a discriminatory way, there's a very explicit pathway that we've asked folks to follow. The short answer is it's escalated locally first to your initial manager or supervisor or training service boss or whomever it might be, and that the patient civil rights coordinator is also contacted. Depending upon where it goes, it also may go to the administrator on call or patient relations and clinical risk. Again, there's very explicit rules in here of how to call and who to call, meant to make sure that these cases are appropriately escalated. The other thing that's built into this is anything that puts you at physical risk or a threat to your body, call security immediately. Don't read anything further, right? So you call security and you take it from there. But the first thing is make sure that you are safe, and then we can deal with the rest. And then we also have a patient civil rights grievance procedure, and all of these contexts and contacts are in the policy and in the document. All of this is available on the internet through our webpage. There's a different one for alleged discrimination from a UMHS work. So this is for patient, family, and visitors, and this is for workplace. Again, same idea, just different workflow. And then finally, how does it work when there's a director, supervisor, house manager, administrator on call? So it tells them how to do this and escalate it from that level. So the bottom line here is we have strived to create a policy that deals with issues head on, that is fairly straightforward in the fact that we will not accept behaviors that run tantamount to Michigan Medicine's philosophy, but also that gives some flexibility and leeway to allow people to judge for themselves when and when not to consider leeway. So with that said, I've spent about 20 minutes presenting that, and the much more important part here will be our panel. So I will invite our three panelists to come up here, and I think the format that we'll use is give them each a chance to make an opening statement or review or summary of their own experience and perspective, and then open up some dialogue and Q&A. So why don't we start with Kamau, if that's okay. There's a mic right behind you, and I'm going to come sit next to you and go from there.
Testing. All right. First of all, I want to thank Andy and those who have put this policy together for that complex and hard work and thought to confront the difficulty of what could be called, oppressive behaviors. So, thinking about this session and reading over the slides, it actually a prayer came to mind from my tradition, and it's a prayer of the Prophet Muhammad as he left his house, and for his followers to, invoke. So we leave on our left foot when we leave the house, and it would go like this, and we can think about it as relevant to this. It says, "O God, I seek refuge in you that I stray or am led astray, that I slip or am made to slip, that I oppress or that I am oppressed, that I carry out acts of ignorance or acts of ignorance are carried out against me." So, coming from this idea of, the spiritual dimension, psychological, emotional dimension of how these laws and frameworks are put in place, but on a daily basis, on the daily grind, they say, what is that? Just to bring up that idea of, as human beings, what do we go through internally for one, as staff people, perhaps having power and a sense of privilege. How many of you have been on both sides of the patient and staff spectrum? Is the contrast quite high? I'm just curious. I think it is for me. So just one, acknowledging that when we walk out into our day, we walk out into the hospital, we do have power within us that we should acknowledge and respect, and that that power can be used to harm or to benefit, actually, enhance. One of my colleagues said, are we enhancing our relationships or are we deteriorating them or eroding them? And also that we have that we're in positions where we're opening up to people to serve them, to help them, and they may take into their own hands, out of their own vulnerability or discriminate or hate, to harm us physically, emotionally. So that's kind of the foundational thought that came to me about being aware of how do we center ourselves. What does it mean to be centered? And what are we centering into? And what are we trying to avoid on a daily basis? And for us to think about that in our own ways, in our own traditions, because policies are giving us a framework, but we're also creating a culture where, to be honest, it can be very difficult to respond based on how vulnerable you are or how empowered you feel as a staff member. And conversations within my department as well, because I brought these ideas to our department, is just that, there are people on our staff who are more powerful for different reasons than others. Could be by their pay grade, it could be by their gender, it could be by their ethnicity or their religion. By being a majority, there may be this sense of familiarity and ability to respond with empathy when you identify with someone who had received discrimination. Also, for another person who, for any reason you may not identify with as much, it may be difficult to respond. We can sort of dismiss, So I think that's the sort of piece of nuance that, I invite myself and us as a community. Hopefully there are more forums to be able to reflect on, how do we navigate these awareness of our own power, our own vulnerabilities, and how do we create a culture where we can, get the best out of both, get the best out of our vulnerabilities, when we're afraid or uncomfortable, taking note of that. Oh, there's a learning opportunity here. Is it just black and white, or is it nuanced? And also, like, when we come into a situation, how do we use our power? Do we suppress or oppress people because we don't want to see what they're really going through, or we don't understand what they're going through, so we use that power to oppress them, or that power to enhance their experience of vulnerability that they may be lashing out from or coming out from. So hopefully I complicated it a little bit more for you in a positive way. But again, I think reflecting on what it means to be centered, and that we're struggling with duality all the time, us, them, they, me, and is there space to cultivate within the practice of medicine a wisdom about what it means to be centered culturally, institutionally, so that our communication will be empowered, and effective in dealing with the complexity. Is that enough time? Did I take up enough time? All right.
Do I go next, or Denise? Okay, I'm having trouble seeing folks because of the light, so I feel a little strange right now. But I love what you were talking about in terms of that nuanced existence. things so often aren't black and white, and that's why I wear gray today, if you know me. And walking around with the geriatrics team, I'm often wearing black. It's easier to get dressed in the morning when things just match that way. But really, I think that every day for me is living in gray. None of the consultations that we're asked to see are so clear. If they are, you don't need our team. And so I'm fortunate that I work with an interdisciplinary team. The geriatrics team here consists of a geriatrician, a nurse practitioner, and a social worker. So I feel pretty fortunate that at any given time, we really do try to look at each case as an individual situation. And we try to look at these experiences that the second case study was pointing out, is that this person was in an earlier stage of dementia, so seemed cognitively intact in many ways, but we still recognize, at least from our lens, that the brain isn't functioning quite as well as it might have years ago. I do want to make just a brief comment about, in the introduction, Andy talked about that folks say things when they have dementia that they might not have said when they were younger, and that part is probably debatable. Sometimes folks might have had those thoughts. The difference is the ability to filter what they say, and sometimes we give people the benefit of the doubt. I was a social worker, that maybe really raising their prejudices and their beliefs. But with time, as dementia sort of manifests itself, the ability to manage those behaviors really gets, it becomes impossible, truthfully. So I wanted to use my time to talk a little bit about the differences in these behaviors. So just it's sort of touched on already with the geriatric consult team, but we see folks for a variety of reasons. Sometimes we work collaboratively with palliative care for folks we might know from our clinic, but the majority of our consults are either for capacity evaluations or BPSD. Who knows what BPSD is? Anyone? So the silence, the crickets, points out the fact that this is an area our institution needs to keep learning about. Behavior and psychological symptoms of dementia. We see it in the chart as AMS, altered mental status, agitation, aggression, confusion. And so these diagnoses that we're seeing really point to a significant problem that we're seeing. And as people are aging, the baby boomers are aging, we're seeing a tremendous increase in the amount of dementias. And the challenge is dementia. Anyone have a sense about how long an Alzheimer's span could last for? 20 years. So we're seeing folks anywhere up until 20 years. So if they're in year 5, they're in year 10, they're in year 12, depending on how smart they are, how much reserve they have, how many supports, any other social determinants of health that have contributed to their situation, they might still present pretty cognitively intact. And because of that, we're not going to recognize that they have a cognitive disorder or a dementia. We're going to assume this person is a pain in the ass, and they're prejudiced, and they're discriminatory, and they are just difficult people to work with. So we get these people. Our team will get many of these situations, and we try to sort out the behavior with their roommate, the behavior with the staff. They're not compliant. They're being resistant to care. They're being difficult. And so we try to sort out what is it we could do to help the situation. And so I wanted to take the opportunity to talk about another few very specific sorts of dementia that make this especially complicated. Just a show of hands, how many folks have feel like you have the ability to recognize a person with Lewy body dementia? A little higher if you're raising your hand. Don't be shy. I can't see you anyway, really, but... Okay, how about frontotemporal dementia? How many people feel like you could recognize a patient that has this diagnosis? Okay, so at both times, less than 10 of you raised your hands. And that's been my experience in working with providers, even physicians and nurses who have been working with clients for 20, 30 years. They have a tremendous amount of difficulty recognizing the symptoms of these conditions. How about delirium? How many people feel like you could recognize a person that's delirious? Okay, so a few more of you, that's great. I think delirium is especially tricky in our lens of what we look for is when there's already a diagnosis of dementia. We miss delirium so frequently because with older adults, we're often making the assumption that this is just their dementia getting worse. And so we miss the opportunity to treat conditions that would cause the delirium. Notice I said treat the condition that causes the delirium because there's no treatment for delirium, which is another thing that's very challenging when we get consulted. A lot of folks will say, well, this person is being challenging to work with. They're being difficult with our staff. Can't you just give them something? And the challenge with delirium is that if we medicate that, it actually makes it worse in many situations. Now, years ago, I graduated in 1997. I worked in healthcare right away. Truthfully, we snowed people, and they were real easy to take care of. We don't do that anymore. So the Beers criteria has been rolling out progressively over the last 10 years or so, that list of meds that we don't want to use because of black box warnings or because we know we're actually making this delirium last longer. We don't use them. What are we telling you to do in the field? Non-pharmacological approaches. Be patient. Talk kindly. Explain what you're doing. And while we know those things work often to try to help a person through this delirium and try to ease their concerns as a person with PTSD, it's not practical for us. You know, people have lots of other patients to see, especially if they've been offensive to us in some way. It's really challenging to be patient when someone has just called you a really bad name or says they don't want you to care for them. So while we recognize that these conditions are significant, and I just want to point out for those of you not familiar with dementia with Lewy bodies, some of those conditions, they don't necessarily look like dementia because people don't have memory symptoms right away. They're more likely to have psychotic sorts of symptoms like hallucinations. They might just act a little bit bizarre. They're very likely to have sleeping disorder issues, and they may have some rigidity or stuff like that. But the one that's the really most challenging that we see, and I feel is it's just a diagnosis I hope no one I care about ever gets, is the frontotemporal dementia. What we know about this condition is it tends to manifest itself between 45 to 65 years old. So these are the folks we really don't know until they either end up in jail because they've done something really bad, or they've got fired from their job, or they punched their son-in-law. You know, these are just the kind of things that things have to be pretty far along the disease process until we recognize it. And so while we strive for these behavior contracts, and we absolutely need to keep doing that for protecting all involved, I just wanted to share this other perspective that there are many other conditions beyond our control that we're still learning about. There's so much about the brain we don't know about. But use our service. We'll try to help you. Psychiatry folks are great here. We don't have geropsych here, which would be super helpful, but it's not a consult team that's offered. But that's kind of what I wanted to point out in some of my time. Keep doing the great work you're all doing, by the way.
Oh, great. Now you add in the lawyer, right? No, it's really interesting because when Andy had first asked about this topic, some time ago, my first thought is we get in the legal office, and I'll speak on behalf of patient relations and clinical risk, some folks are here as well, we get a lot of calls about, we just want to terminate this patient because here they've done A, B, and C. And so what has resonated with me is that a lot of the clinical folks try to make it a legal issue. And certainly my message is we do not tolerate, any sort of harassment or abusive behavior or threatening behavior. But I think in my experience, excuse me, I've been a healthcare lawyer for more than 20 years. And what I have seen in my experience is you do all tolerate it all the time, more than you probably should, more than maybe you think about. And that doesn't mean everyone is, committing some crime or this is so nuanced. But I think what happens is we have gone through this stage in healthcare where and I appreciate your slide, Andy, that, the customer is supposed to always be right. And in fact, they're not always right. But we have patient satisfaction scores. We have Joint Commission standards. We have CMS regulations we have to follow. I mean, the list of references from a legal perspective in this policy is almost a page long of all the things that we had to look at in order to protect our patients. And so the easy answer, easy being a relative term, is that an individual provider or a group of providers decides to say, okay, we'll honor that request, or we'll walk away out of that room. That really resonated with me today when you talked about an individual person making the decision to say, okay, you don't want me, I will walk away. And the moment we start to do that, more exceptions come and more exceptions come, and we don't have consistency that we could show, no, in fact, we have done everything appropriately. The main concern in all of this is that we would somehow be, the patient would allege that we have abandoned them in some way or not given them the care they wanted or requested. It's a pretty hard standard to get to, I will tell you. I can think of one case I've had in 20 plus years where we actually got to that point. So I just use my time to tell you all, don't be afraid of that. But what's also interesting, I think about on an outpatient perspective, folks who come into the clinic frequently, and their behavior becomes the norm for all of you. And what I start to see is a little less documentation about the offensive words or the requests or things that happen. And then when we want to make a decision that perhaps, in fact, this isn't maybe one of those nuanced situations or where we could have a teaching moment and we would want to take action, we don't have a lot of support for that. You all will think that you will remember every difficult patient or a patient who's made, like Frank, who's made that request. You will forget Frank's specific language a year down the road, 2 years down the road. You'll just remember that Frank is a pain in the ass. And that's my thought to you is to, if you've got people making these requests, we need to know about them. Please follow that escalation process, because the more we can learn about this as well, we have an opportunity to do more education, both community-wide, internal for all of our staff, because I do still think we have a gap of our providers who believe, I should just walk away and honor this request. So, we want to be making sure everyone is protected. And yes, we honor our patients' rights, but yours are all pretty important as well. So we're here to support you. So my 2 cents for the moment.
Let's open it up to the audience. We can certainly have some dialogue up here, but it'd be great to hear from you as well.
Thanks very much, guys. That was really thought-provoking and helpful. And then you started to get to the end. I wonder how you think the policy does or doesn't help in situations where the stereotype is there, the hateful language is there, but the discrete request that you can honor or not isn't. So you have that same Frank, but he's not asking for different providers. He's just sort of contributing to an environment that makes everyone uncomfortable by telling us what he thinks about people. And where does sort of free speech and hospital policy move?
Great. Just for the folks listening at home, I'll briefly paraphrase the question, which is essentially, what do you do with racist jerks who aren't asking for anything specifically racist, but just are acting in a way that is not the way we want them to?
You all probably have comments on that. Yeah, same thing. It's not allowed. It's not simple to just be like, hey, you're being a racist jerk, get out of this office. But it's a teaching moment as well that, we don't tolerate this behavior. Here's why. I always tell folks, remind them of here's our policy about that. That sounds a lot simpler. I'm not a provider. You all know that. So that sounds pretty good. But any teachable moment, and then that's when I tell people start documenting that as well, because we may then decide this person does not need to receive care here, and we will make sure they can, have an avenue to receive care, but it may not be here, because we don't want anyone to feel that they can't come to work and provide the care that they have. So it's not a simple answer. That's kind of you'll end up talking to us or patient relations and clinical risk. They get a lot of those calls, but we want to help with those as well.
We were having a group conversation in our huddle earlier about a chaplain resident that recently had a referral of a man who was using very racist language, and the doctors, so the complexity of it is the doctors were telling him that, this is the end of your life, and it seemed like they didn't like him. He already had this reputation of being a bad person. So the way that they did it was sort of, exacerbated his racist behavior. And then the chaplain resident was called in to calm the situation down. So this is, the stickiness of going into the situation, trying to figure out what's going on spiritually and emotionally with this person. They're basically he was like 70 pounds in a very very vulnerable situation, but still very rude, and sort of using his whiteness to say, if I was another color, then I would have been treated differently. But there is just so much to that because he had been poor all of his life and he had had a hard life. That was his narrative. So, and the nurses were on the side of the patient as well, against the doctors. So, as you focus in, how does this picture develop, and how do you find justice? How do you find what is helpful? And which raises a question with just to know what is the trajectory for someone who's saying, I will not have, this person as my provider. What happens to them? Do they go to like this special place?
So I'll relate an anecdote of my own, which was taking care of a patient with a horrifically recurrent, nasty head and neck cancer who's covered in swastika tattoos, who made very clear in no uncertain terms how he felt about me and, quote unquote, my people. And I have fairly thick skin, and I am fairly clear in my language, and told him what was and was not acceptable in terms of our interaction, and laid down some fairly clear ground rules. But I was comfortable taking care of him. And from my standpoint, I could deal with this. The learning point for me was how awful he was to the rest of the team, regardless of their religious creed or appearance or anything else. And I think my error in judgment was not making clear that even if I could tolerate his behavior, other people shouldn't have to. And the consequences of taking a patient on, especially, quite frankly, as a surgeon, commits the rest of the care team to taking care of that same individual in a way that they didn't necessarily ask for. And I think one of the lessons from that case for me is that dealing with that behavior initially is not just about your individual interaction, but rather that person's interaction with the rest of the team. And what we've tried to do in this policy is be more recognize that aspect, that Michigan Medicine is not one provider or one set of providers, but rather all of us, and is yet another reason why we shouldn't be quite so permissive of behavior that one individual says, well, I can deal with this. Other questions and comments?
Also knowing that safety is where white women feel unsafe. If there's any nuancing so that we don't say that we just
Now, I'm speaking a bit on behalf of the security folks, and I won't do it justice, most likely, but just my thoughts. And I admit that's an excellent question that I have not given a lot of thought to, so it's kind of off the top of my head. But security does a good job of trying to do a threat assessment, right? If you call them, regardless of the reason for the call, that you feel unsafe, they want a lot of detail and tell me why. And they may probe into some uncomfortable questions to you about your, it may come out that you have maybe some of these biases or whatnot. Not that they're going to do anything with that, I don't mean that at all, but just to determine, is this actually perhaps a physical threat right at this moment, and, can we do something differently? So that would be my guess, is working with them to really assess whether it's from their perspective, something they would intervene in. And I know that's not a great answer, but it's my thought at this point.
Yes, to The folks that might have frontotemporal dementia fall into this category often because they're often sexually disinhibited. And so we will have folks, staff reaching over and having somebody grab them inappropriately. And despite how many times we tell them not to do that, it isn't going to stop. And so this creates a obvious safety concern for the staff person and a violation that they should never have to deal with in the workplace. At the same time, we have this patient who, where would we send this person, right? And that's often the consult I get too is, okay, can you send them somewhere? Okay, where am I going to send them? They're going to do this wherever they go. What do we do with people that do this? There aren't great solutions. So I think these cases, when a person feels unsafe, whether it is a legitimate sort of threat or not, they feel that way. And I think there has got to be, and I hope these policies and talking about this encourages people to feel safe going to their direct managers, problem solving. This would be one of those cases where our team's recommendation would be, this person probably would do better with male staff. Like, let's just problem solve a creative solution. We may not be able to do that all the time, depending on who the specialist is or what their situation is. But I think it points out that one size does not fit all, and that as providers who went into the medical field to help people, there will be times, not just the jerk, but there will be times that we still have to just problem solve around. And trusting guts. I mean, I think the supervisors, legal department, security, trusting people's guts if they don't feel safe for whatever reason, that we should feel like we can go to somebody with that and try to get support in some way. That's my thought.
Still want to know where patient purgatory is.
You don't want that option, I get it.
So recently on NICU, I was called into a situation where there's a young African American mother, a single mother that had behaviors like cursing and sort of like get back from me, don't touch me, get away from me, and security was called. And later on I was called after things had calmed down, actually, in this case. But what they did do is they called in her sister and also moved her in a different space to where she could just calm down. And the nurse that she had conflict with remained the nurse, and there was resolution there. I mean, I thought that was like a positive, right? Because there is this thing of, why did you have to call security? Okay, I was in a bad place. I was in a bad mood. I felt vulnerable, essentially, and you called security on me. So there is still that strong symbolic presence of an officer that can be a double-edged sword, and but in this particular case, it sounds like things were redirected, and she was not sent to purgatory. Thankfully, she recentered herself, and even her nurse was able to recenter herself.
I think in my world, we talk about every behavior as a form of communication and trying to figure out where that's coming from. And so even for, as hard as this is to say, is even for people who are clearly discriminatory and inappropriately not wanting to work with certain people, they have this perspective about fair treatment or good treatment. And it doesn't mean we accommodate that in any way, but it is just us as providers trying to see where that's coming from and then figure out how to handle that. In the world of dementia, I look at that differently than I would with folks that don't have a cognitive disorder. But we think about the amount of people we work with that have histories of trauma, that have other social determinant issues that have impacted their view of the health system. And similarly, for example, the older African American people I work with often really don't trust white providers, so there are different conversations we have with some of them and their families. So it really is taking time, if we can, to understand what these behaviors might represent. And then as an institution, should we try to accommodate that? And if so, how would we do that?
I think we're short on time. I want to thank everybody for participating and for your attention, specifically to our panelists for really a wonderful conversation. Thank you so much.